Welcome to Centennial Oral Histories, a series featuring former and current leaders of Duke University and Duke Health, sharing memories of their time at Duke and their hopes for Duke's future. Enjoy this discussion with Dr. Bill Fulkerson, a professor of medicine and former executive vice president of Duke University Health System. He is interviewed by Ann Pelham, a Duke alum and member of the Board of Trustees.
I'm Ann Pelham, and I'm honored to be here today with Bill Fulkerson to talk about his illustrious career at Duke and to learn more about not only what you've done, but how you've learned from Duke University and Duke Hospital and what became Duke Health in recent years. So I'd like to hear a little bit first about your early career and how you found your way to Duke.
Well, Ann, it's an interesting question because I actually came to Duke as a trailing spouse in 1983. I was finishing up my pulmonary and critical care training at Vanderbilt then. My wife, Mary, who had been a divinity student here at Duke, was finishing her PhD at Vanderbilt in theology. I had already accepted a job at Vanderbilt to stay there on the faculty, and then Mary, my spouse, got a call from Dennis Campbell, who was the dean of the divinity school, wanting to recruit Mary to come back and join the faculty at the divinity school. I was 3 months from being finished, and so I had to rush over here and interview with people in the pulmonary division and the Department of Medicine, and got lucky and was offered a job. And so here we are. In July 1983, we come back to Durham, North Carolina, and now we're still here 41 years later.
It's a great story. I don't want to use the Tar Heel word inappropriately here, but you did go to the University of North Carolina for your earlier degrees, your medical degree and your undergraduate degree. How has it been to be a former Tar Heel in the midst of all this Duke Blue?
Well, as Dean Klopman says, I was at UNC for 8 years, but I've been at Duke for 41 years, so I'm a Duke man now. I did get a Duke degree. I got my MBA at Fuqua back in 1991. No, sorry, 2001.
Right, and I know that that was an interruption of your career, but you didn't stop working. So it must have been quite an experience to go through that.
It was a very challenging 20 months. Yes, ma'am.
So I don't want to get us off track. I know you've had a number of roles at Duke. One of them was during that time you were running the private diagnostic clinic. But why don't you take us through how you emerged from the role of clinician and researcher to the one of medical leader and the person who looked over the hill instead of the person looking at the patient.
Well, you're right. When I arrived here, I was a clinician and a researcher doing primarily patient-based research, clinical research in the ICU. I got very lucky in having some colleagues here who invited me to work on some projects with them, and very quickly became familiar with the NIH and funding mechanisms and was able to generate grants and get supported. But I was a very busy clinician during that period of time. Eventually, I became director of critical care for Duke Hospital, and that gave me a little bit more of an administrative role and a budgeting role with that. And then following that, I became division chief in pulmonary and critical care medicine when Bart Haynes was chair of medicine here. I did that for about 6 years, and then the chief medical officer of the private diagnostic clinic or the faculty practice here at Duke, followed by chief medical officer of Duke Hospital. Did that only for 2 years because the person I reported to, Mike Israel at Duke Hospital, left to go to New York, and Dr. Snyderman, who was chancellor at the time, asked me to take over as CEO of Duke Hospital. That was in the summer of 2002. Fortunately, there were a lot of smart people working at Duke Hospital, so we were able to pull things together, and it was a very successful period of time. When Victor Zal was chancellor of the health system, he then asked me to come in and work as the executive vice president of the health system over all of the clinical aspects that we deal with the health system. And I did that up until January of 2022.
Wow. It's it's quite an illustrious career, and I think Duke is fortunate that you were there to take on those different roles. How did the growth of the health system during that period affect your goals and priorities for the organization and your own?
Well, the growth was pretty phenomenal during those years. And, people have asked me before, how did you grow so fast? My answer is pretty simple. I think if you are a place that delivers the best care and gives patients the best experience, they're going to come. And I tell people often when patients and their families hear about Duke and come to Duke, they just assume they're going to get the very best. And that's our challenge every day, to wake up and deliver the very best care, the very best quality, the very best experience to patients and their families. So it was never some grand secret strategy or some cute marketing analysis. We had strategy and we analyzed the market, but it's a matter of recruiting the men and women and retaining the men and women that can deliver exceptional care and an exceptional experience to patients every day. That's the privilege of being here, and that's what makes this place very special.
It certainly was growing a lot in those years. If you look at all of the different centers of care that were created, and you redid buildings, I mean, there were tremendous amounts of responsibility that you carried, not only continuing to do what was there, but expanding regularly.
Yeah, there were major building blocks of the health system during that period of time. And, I'll go back to the late 80s. And that's when we started, adding hospitals and actually became a health system there with the Duke Raleigh Hospital and Duke Regional Hospital joining the health system under Dr. Snyderman's leadership then. We started Duke Primary Care. And Duke Primary Care really is a foundation of all we do here. And we brought the primary care practice into the health system. And today it's one of the largest and one of the best primary care networks in the state of North Carolina, I think. We started Duke LifePoint. Duke LifePoint was a joint venture with LifePoint Healthcare to own and operate hospitals in rural areas. We have 9 DLP, Duke LifePoint hospitals in North Carolina, 1 in Virginia, 3 in Pennsylvania, and 1 in the Upper Peninsula of Michigan. And it allowed us at Duke to work with leaders in the rural communities to really help with quality and safety in the products that they deliver there, and help them recruit physicians and nurses in those areas as well. We built facilities, as you said. In the past few years, we've had major additions to all 3 hospitals. We built a beautiful behavioral health unit out at Duke Regional Hospital. We built a large medical office building and a state-of-the-art ambulatory surgery center at Arrington in Research Triangle Park there. And that's really to create the space and the place where patients can come and see our practitioners and experience the best care that's available anywhere.
And Wake County continues to be an opportunity for expansion. Is that fair?
Tremendous growth in Wake County, tremendous demand for services in Wake County, so we continue to expand there.
And with more to come, it sounds like.
Oh yes.
Are there some particular moments that stand out in the history of Duke and Duke Health that you see as most pivotal, particularly from the health perspective?
Well, some of those are things I just mentioned. The formation of the health system, the partnership with Duke LifePoint, the different facilities that we built. And one very recently is the integration of the faculty practice into the health system.
Yes.
That's been work in progress over the past year and a half, but absolutely critical to the future success of Duke Health and Duke Medicine. The other thing I think that has been very important to the practice of medicine at Duke is the academic piece of the School of Medicine and the School of Nursing. That really is part of our reputation, part of what we do. It's innovation, thinking of new ways to approach diseases and conditions, to really offer patients unique opportunities for health and improving health. And so it's been very important to me on the health system side to be able to support the School of Medicine, the School of Nursing, financially and otherwise, because their product is one of the best in the country and is really necessary to the success of the health system.
It truly is a partnership. It certainly seems
Very
to
much
be.
so, yeah.
Are there any particular moments over those years where you were in a leadership role that stand out for you, whether it's a burst of success or a challenge that you're willing to share with us?
Well, there are a couple of things. For me personally, safety and quality have always been paramount in what we do. We had a highly public medical error in 2003, and that led to a reconsideration of everything we do in safety and quality in the health system. We altered policies, procedures, systems. We measured different things. We defined accountability different, and it has led to us remaining at the pinnacle of patient safety and quality ever since then. And that's been very important, but it was a very challenging time during then.
I can imagine. Was there one that felt like a big success?
A lot of things are big successes. I mean, we look at the clinical programs that have been developed by our clinical leaders over the years in cardiovascular disease, in cancer, in solid organ transplant, and a number of other programs. And to see those become the nationally and internationally recognized programs that they are today has been very fulfilling.
So those count among the greatest successes.
Absolutely, yeah.
Is there something particular that you have taken from all of those ups and downs, mostly ups, from a personal perspective compared to the young doctor who came here from Vanderbilt and got started?
Well, I think, everything we do depends on our teams in the health system and in the School of Medicine there. And, it starts with people, it ends with people. And that's what I take as most important to build the strong teams, to enable them to do the great things they do every day, give them the resources, give them the space, and let them take it away.
You mentioned things like the importance of safety and compliance. You also had a big role in creating a diversity and inclusion approach for the health system. Could you talk about that a little bit?
I think that's extremely important. We started years ago working on diversity, equity, and inclusion, and have continued it to today, catalyzed by Gene Washington when he was here as our chancellor as well. It's important for patients that come here to be cared for by caregivers that look like them. And so that's the importance of delivering a quality product, includes having a diverse workforce to deliver that.
So are there particular moments, either in the context of that challenge, which for Duke was greater because of our location in North Carolina over the decades before you arrived, before we both were involved with Duke? Are there some pivotal moments in that history that stand out in terms of building the kind of open and inclusive organization that we hope Duke Health is today, and Duke University for that matter?
Well, I think we, like many people, became even more energized around diversity, equity, and inclusion after George Floyd's death. Again, being led by Gene Washington through this. We redoubled efforts at trying to identify healthcare disparities in our populations and in our city here, devoting resources to that and to try and erase healthcare disparities where we could, understanding some of the root causes around that and attacking those. So I'd say over the last 5 years, it's been an effort that really has redoubled.
The rural counties were not always prepared for Duke to come in. Were there some challenges in that role that you all had to sort of communicate what you could bring to the table without, I suppose, bigfooting your way into the counties?
You know, when we approached hospitals to join our community with Duke LifePoint, we did it in a way that we felt we could offer them some resources that they wouldn't be able to develop or tap. They just didn't have the capacity to do that or the financial resources to do that. LifePoint is financially very strong, outstanding operators of small rural hospitals, and we bring to the table the safety and quality expertise to work with them. And in every case, there have been open arms from the medical staff, from the hospital staff, from the boards of these hospitals, who are eager to understand how they can improve better care in their local communities. So there really hasn't been any resistance at all.
And do you see that continuing to grow?
I think so. We're looking all the time for opportunities to add to the number of hospitals that we have in Duke LifePoint.
That's great. I know that this particular area is growing so quickly. There are opportunities that you might not have imagined back in the 80s and when you first arrived, or even the 90s when you began to be an administrator for Duke. Have you been surprised by the tremendous success and growth of this area?
Well, I think everybody's been a little bit surprised at how fast we're growing. I think Wake County is like the second or third fastest growing county in America today. And so it is a race to keep up. We have formidable competition. But again, I'll come back to what is the product that we're giving to patients. The highest quality, I think, the best experience, and they will come to Duke.
You were here at Duke for the pandemic and the challenges that brought to the hospitals. Do you feel like there were lessons from that your successors are dealing with? I know that financially it was a strain for all hospitals and all health systems. Could you share with us sort of how you see that affecting things going forward?
Yes, I'm glad you asked that. The COVID pandemic was an unbelievable, difficult experience. I think at the peak of the pandemic, the Duke system had about 250 inpatients at one time with COVID. And we had the sickest of the sick here at University Hospital as well. And so we asked a tremendous amount of perseverance on our staff, on our physicians, on our technologists, on everyone to be able to take care of the patients in that period of time. And certainly in the pre-vaccine area, it was a very difficult time with morbidity and mortality from COVID. So it took a toll on a lot of folks. And our goal in the hospitals were to try to provide the safest environment for patients and for our staff that we could amid global business disruption. The supply chain was a disaster. All around the world, the supply chain was a disaster. It really exposed some terrific weaknesses that we have tried to shore up now that the bulk of the pandemic has passed us right now. But I will say also during the very difficult times there that I have never been more proud of our team and what they did to step up and go above and beyond taking care of patients there. And so we learned a lot of things about procedures. We learned a lot of things about keeping our staff safe. We learned a lot of things about anticipating supply needs in the future. And I think that'll that'll help us going forward. We are dealing now with some challenges. We're dealing with challenges in staffing, but that's getting better. As you referenced, we're dealing with some challenges financially, but that's getting better too. And I think we'll come out of this in good shape.
There was so much to learn so quickly. People were exhausted, staff were quitting. I think the nurses were carrying a really heavy load. Is there a different philosophy in healthcare now than there was before the pandemic? Or is it just practices and systems that are different?
I think it's practices and systems, but it's also probably even a deeper appreciation for what the dedication from our staff meant then, and how remarkable the people were that were in the trenches taking care of patients at the time.
Well, we hope that we don't have something like that again, but
Yeah.
you've clearly learned. I think it sounds, what you're saying is that you have clearly learned a lot from that experience, and that the systems are in place now in a more robust way to be prepared for the next pandemic.
I think that's true, yeah.
We might not know what it is, but
We don't know what it is, but there will be one.
are there, have you thought about, or could you share with us your thoughts on Duke's greatest successes? And it doesn't just have to be in your tenure, but are there some highlights from the medical system and the healthcare operation that stand out for you?
Well, I mentioned some of the service lines, one thing that is true about Duke is we strive to be innovative, to think of new ways and new things to do for patients who may otherwise not have hope around that. So in many cases in cardiovascular disease, many cases in cancer, and many cases in solid organ transplantation, we're dealing with some of the most difficult cases there are. Many cases others won't be able to treat. But they come here because of the expertise of our caregivers, and they come here because of the innovation that we can put on the table that come out of the research laboratories at Duke University. And so there are countless things. Even this year, a unique heart transplant in neonates, first in the world, done here. And those kinds of things happen all the time.
Is the transition from the private diagnostic clinic and the integration of all of those physicians after how many years has it been? 70?
Almost
80. Okay. Yeah. How do you see that affecting the hospital? I mean, do you feel like the high level of innovation and standard of care is adjusting? Are you able to carry on with this transition underway?
Oh yeah, I think so, and I think I don't think we would have considered the integration if we didn't think there was a huge upside to it. It allows the health system to capitalize the growth of the faculty practice. We could not do that legally beforehand, and that many times handcuffed what the faculty leaders could do in their domains. And so this is a big opportunity to move things forward.
So you're saying capitalize the growth, and that the growth stayed in the PDC and the profit stayed in the PDC, and you were not able to use that to build up the health system.
That's correct. If the PDC, if we, the health system, wanted the PDC to do something that was less profitable, they had a hard time doing that for obvious reasons. But now that doesn't have to be the case. And I think the main thing about integration of the faculty practice is the ideal thing to me is I want every member of the faculty to feel like they own the place and to work like they own the place and be a partner with everyone else in the Duke Health enterprise here. And I think that will unleash a lot of energy and enthusiasm and opportunities for the future.
I like your optimism.
Yeah.
Maybe you could help us with a little history about the PDC, why, when Duke was so new, the decision was made to set up something separate like that?
Well, I'm probably not the best one to answer that, but I can tell you that it was started in order to give physicians an opportunity to have a private practice while they were also teaching and doing research at Duke. This is back in the 1930s.
It was a recruiting tool.
Yeah, yeah. And it's been a very good thing for a long time. But because reimbursement has changed dramatically in medicine, everyone can't support themselves. It really has to be what is valuable to the enterprise, and the enterprise will support that. But the PDC has been entrepreneurial. It's been aggressive. They have grown. They've been a huge partner to the university and to the health system. But the reimbursement mechanisms now make it very difficult to be in a lone for-profit practice.
There's not much profit left.
That's right.
And how many years would you say that conversation had gone on about the PDC before you managed to come up with a resolution?
20.
I was going to guess, but not that big. So in your career, you thought about the PDC every day.
I work with the PDC every day.
Right. Well, you ran it for a while.
I was chief medical officer there, but I worked very closely with PDC leadership the entire time I was in the hospital and the executive vice president, because we needed the faculty practice, and the faculty practice needed us to be successful, and we were very successful.
And it seems to me from the outside that the PDC, the relationship between Duke and the PDC was really unique by the time everything has been resolved in the last few years. Was there anything like that left in the United States?
I don't think so. No.
Yeah. So for your career, you were operating with different entities and trying to make sure everyone was still communicating properly and managing their separate finances. That was an additional challenge, I'm sure, on a almost daily basis.
That's correct, but we had constraints of things we couldn't do together legally, and that's where it would frustrate faculty, frustrate others, to not be able to get the support they felt like they needed to move forward with some initiative. Now it's going to be much easier to do that.
Everyone's rowing in the same direction, as they say.
That's what we hope. Yeah.
Well, it is, I suppose, still an evolving integration. It will be, how many years do you think before people stop talking about integrating and continue on their way?
I don't know exactly. I've had conversations with a few of the clinical chairs just in the last week about that, and everyone thinks it's going to take a few years to grind out some of the issues that need to be resolved, but they've done a huge amount of work this year, and taken major steps forward. So I'm very optimistic, as you said, that things are going to get better and better and better.
Do they? Are there some successes in Duke's past that you think may have been easier to achieve because of the structure that you had before, or are there places where it was a challenge?
There were also always some unique challenges there, but as I said, we were able to work through most of those in some ways until it just became difficult financially to make things work because of the barriers and constraints across the organizations there. And it would get a little bit worse every year, a little bit more difficult, I'll say, every year to make things move forward. And so I think we're going to be in a much better place in the future.
You were a leader at the top level for such a long time. Are there, when you look back, are there places where you wish you had known then what you know now about a particular thing? That one of them being maybe the integration of those two entities. But anything else that you look back on and recognized later?
Well, I think probably everything. I mean, we're a learning organization, and so every year we learn how to do things better that we maybe couldn't have anticipated before. And so, I think history teaches us a lot every time about where the opportunities are and where the pitfalls may be. So I would say the answer is everything.
You're an optimist, which I think is important in healthcare. We always want to believe that what the doctor tells us. There's some terminology I just want to get straight for the record. Could you just walk us through the names that you've called Duke Hospital over the course of your career? The entity that began on campus and began to grow and then expanded.
Duke University Hospital is still Duke University Hospital. We became the health system, as I mentioned, when now Duke Regional and Duke Raleigh came in. Raleigh was acquired. Regional is a long-term lease with Durham County. Both of those negotiated by Dr. Snyderman. Duke Health really is a term to describe all of the medical and clinical enterprise, both clinical and academic there, and nursing, and other things that are related to the medical enterprise. And I think Duke Health may have been coined by Dr. Washington.
Yeah, I think
so. There, but it really is just meant to say this is everything that is related to Duke, including the medical school in Singapore. That is all under one umbrella, and which we're all a part of.
Are there some successes that Duke Health has, as I use the proper term, Duke Health has achieved that you think deserve some attention and recognition?
Yeah, well, I mentioned before the academic piece,
right.
And people may think of the clinical enterprise and academics as being separate and different, but they're really very tightly linked. And it allows the clinical enterprise to offer a lot of innovative ideas, innovative solutions that come out of our laboratories to the patients that are coming here for care. And so the support of the academic piece has been vitally important, I think, not only to the success of the School of Medicine, but also success of the health system too. And so I think that's been very important. Singapore has been great. It's been a terrific success. I've been there once to give lectures on academic health centers, but there's ongoing work with faculty at Singapore and here at Duke and the relationship there.
The positives are everywhere that we see, and I know you mentioned one of the challenges as you consider the accomplishments of your long and really fantastic career there. If you had to think of the top 3 things that made you smile the most, what would they be?
They would be the patient safety and clinical quality that we have achieved and remain leaders in. It would be the patient experience. We are rated very highly compared to peers for the patient experience. And it would be the men and women that come to work at Duke Health every day. One of the very positive things about Duke University and the Duke Health System is we serve as employers of choice in our communities. Some people don't know that Duke University and the Duke University Health System are the second largest private employer in North Carolina.
After Walmart or something like that?
Walmart's number one. Yeah. Personally, I'd rather work at Duke. But we make good jobs in our communities. And I think most would say that we work very hard once folks are employees of Duke Health. We work very hard to give them opportunities to grow and opportunities to expand. And that's extremely important to retention of all employees, including faculty. And so the third thing I would say is I'm proud of the faculty and the nursing staff and the employees that we have, and gratified that we're able to offer in our communities the kinds of jobs that we do.
The challenge of staffing right after the pandemic is something that it sounds as if Duke has overcome. Is there still a struggle to fill positions, or are there some initiatives that you think are going to help with that?
It's much better than it was, but it's still a challenge there. We need to continue to think about how to make work better for everyone, make work more satisfying for everyone, take some of the needless burden off the workforce where we can through different systems. And that's an ongoing promise that the leadership makes to our folks.
Could you give an example of that needless burden?
Okay, so we have an electronic health record. And the electronic health record will take messages from patients back to physicians. That can be overwhelming for clinicians to be in the clinic all day and come back and find that they've got 40 messages to go through.
And they're not paid for that. Is that
That's
part
correct.
of it? Okay.
That's correct. And so we've developed through machine learning, artificial intelligence, a way to triage those messages electronically to folks that can answer them or deal with them that may not be the clinician. He or she may not be necessary to reschedule an appointment, for example, or to refill a prescription or things like that. And so this is something that's just being worked out right now, but I saw a model of it yesterday and it looks very promising, and that would save people hours a day potentially in work. And so that's an example. There are probably a dozen other things that can be solved without relying on the frontline clinicians to do all the work.
So the AI filters out the things that the physician needs to help address, and then sends the others on to someone else.
Right.
That sounds like a great innovation.
Yeah.
Well, who knows what it will look like in 10 years when we're much grayer. It's a great example of innovations that continue, and I know that you saw a tremendous amount of that over the course of your career. Are there some individuals the key individuals that you think have been particularly important to Duke Health?
Yeah, well, I've been blessed, Ann, to be working here a long time. And so I've worked with a lot of different leaders. The university presidents sit on the health system board of directors.
Right.
And I guess I have been pleasantly surprised at how active and how insightful they are, starting with Nan Cohan, then Dick Broadhead, and now Vince. I got to know Dick pretty well because I was an interim president of the health system between Victor Zhao and Gene Washington, and I would meet with Dick routinely to go through the critical aspects of things we're making decisions on in the health system. And I came to depend on him for advice. It was just a remarkable experience. And so I'll start with the university presidents. I've worked with great chancellors, starting with Ralph Snyderman. Ralph was the person that gave me my first job in the health system.
Yeah.
And Ralph was terrific and was a strategic thinker, and as I said, started us down the path of the health system. Victor Zal was terrific, a great mentor, a brilliant man, and was very valuable to work with him, and Gene Washington the same way. So 3 great chancellors, and in some ways I worked for a 4th chancellor because Bill Anlian would come see me. He and Mary Siemens would come see me in my office about every 6 months, just to give me some helpful advice. Something they picked up at the Bridge Club, I think, and they were always very nice.
And what was your role when they were coming by?
Hospital CEO,
Okay.
and EVP of the health system. I would always get a note. In fact, I saved most of them from Mary Siemens, saying, just want to make sure that this was not criticism. We were just giving some advice here, and so I got to know them very well too, and it was good advice during that period of time. I've worked with tremendous people in the School of Medicine, deans. Sandy Williams was terrific. Nancy Andrews, same way. And Mary Klopman, I've known Mary for 40 years, and so it's been a pleasure to work with them and be a partner with them in advancing the academic roles as well. I've had terrific leaders in the hospitals that have really set the tone and maintained and even continued to improve the safety and quality delivery in the hospitals. We've had terrific nurses and just some of the most outstanding nurses I think anywhere here, and nurse leaders as well. Our physicians are the best. I just personally, I would not get care anywhere else. And the physicians are fantastic and are selfless in their dedication to taking care of patients. And our employees and staff and technologists are all here to do whatever they can to make the patient experience as good as it can be. So just some very, very, very remarkable people over the years.
I think you're an optimist, Dr. Fulkerson.
Yeah.
You would be a good boss because you would always think that the person could get better the next day.
Well, that's the point. We're always getting better. That's the whole thing. That's sort of a good summary of the philosophy. We can always get better, even if we're the best in the world. We can always do better, and that's what makes Duke so great. Is always aiming to get better.
The challenges have come through the years, and you've ended up on the hot seat more than once. Would you be willing to suggest what the greatest challenges are for Duke Health over the years that you've been part of?
Well,
or looking forward to?
Looking forward, there are a couple of things. If you just think about what the future of healthcare is here, it's going to be phenomenal. Especially, every day I read a story about some new gene editing tool that's offering a cure for a previously fatal disease. And the gene altering capability going into the future is going to change the picture of medicine, I think. The downside of that is it's going to be expensive. And it comes down to how much we can afford, how much a patient or their family can afford, and trying to figure out how these great advances in medicine don't create deeper healthcare disparities. And I don't have the answer to that, but I think it's something that's knocking on our door right now. It's not 10 years from now, it's right now, when it's going to cost millions of dollars to give somebody a treatment course for an otherwise fatal disease that could be cured with this. And how we design a system that recognizes that and makes it possible, I don't know.
It's almost an explosion of better outcomes,
Right.
that cost way too much money for us to afford in the system that we have.
Right.
and it's already a challenge to give people the care they need. So that aspect of it, the philosophy of how do you decide who gets these cures, they really are cures, is going to be a big challenge, I think, for healthcare.
Absolutely. Even bigger than it has been before. We certainly have some of that today.
Right.
With the problem with uninsured populations. But this is going to be a whole new ballgame, I think, and multiply the problems today by 10, and that's what we're going to look at in the future.
And for not just the United States, but so we have all this hope, and yet we need systems to be able to deliver the hope.
That's true. That's true. And I can't even imagine the kinds of cures that are going to be coming down the road, but they're going to be coming fast, I think, and how we intelligently and deploy them to people who really need them is going to be the challenge.
It makes, in some ways, the current challenges of dealing with your health insurance seem like chump change. I mean, they're always life and death questions that face someone in a healthcare situation. But what you're saying suggests that we're going to have more hope on one hand and a lower ability to deliver the access to those hopeful improvements than we do now, because the number of solutions is going to get up here, and our resources to achieve them are still down here. Is that too pessimistic? I know you're an optimist at heart.
I don't know. I think that's what I worry about. And how you solve something like that is above my pay grade right now. I'm not sure how to solve that, but it's going to be a hot issue to grapple with over the next 5 to 10 years.
So, is there, in your current role, you're not really completely retired, or is that the sort of thing that you are asked to think about from time to time?
Well, not yet. My role right now is primarily helping to support the School of Medicine, primarily from a financial point of view. But I would be very interested in public policy too. I don't know what I'll do in the next 5 years, to be honest with you right now.
But you're enjoying the role that you have?
Yes.
You don't miss being the Uber boss of it?
It was time for someone else, I'll put it that way.
All right. We're having this conversation already about the best and worst of what may be to come in healthcare, but is there something else you want to share in that big question?
No, I think that's it. Just that there are going to be phenomenal improvements in our ability to treat disease and to affect outcomes. And it's going to be, the challenge is going to be how we're going to financially support them and make them available broadly to patients.
Yeah, the finances are already a problem, and right. We're going to have more solutions, and they're going to cost more. So
correct.
Duke University and Duke Health have been together for almost 100 years. And I think the hospital was a year behind the university. I don't know whether we're just going to roll our Centennial celebration together. But what are your hopes for both institutions, and even in a way their partnership as they enter the second century?
My hope and my clear belief is that Duke University and the Duke Health will continue to be national and international leaders in what we do in all the missions, in research, in education, and for Duke Health and patient care there. I grew up in North Carolina. Duke has always been defined as excellence as far as I can remember. And I think that's what it's going to be forever. And to maintain that excellence, they will be a leader in whatever we decide to do here. And so that's my expectation and my true belief that Duke will continue to be one of the elite, excellent places, advancing education, advancing research, and advancing patient care.
There are some naysayers who believe that Duke has gotten to the point where it's too small to be financially competitive, I guess, in the national scene. How do you feel about that perspective?
Well, as far as the Duke clinical landscape, I think, and I know the leaders are looking at opportunities for either joining other organizations or the other organizations joining us. I think a bigger footprint could be important. At the same time, we discussed about the number of people that are moving here every day. Our census at Duke Hospital today is over 1,050. There's not an empty bed in the hospital.
What's the context for that from 5 or 10 years ago?
When I was CEO of Duke University Hospital, sometimes on weekends and certainly over holidays, we would dip below 500 patients in the hospital. Wow. So it's more than twice. So the demand is there. The question is whether we need an even bigger footprint to continue to financially invest in the things we want to invest in, including the academic enterprise. And I think the ideal thing would probably be to continue to look for partners and see what's possible, if it makes sense in the context of our missions and what we're trying to accomplish.
There was a period of time when the medical school was benefiting from financially benefiting from the health system. How do you see that returning in the future?
I hope so. I'm not as much in the weeds now as far as the finances of the health system, but I know it's getting better coming out of the pandemic. And my hope is the kind of support that was able to be given to the university and to the School of Medicine and School of Nursing will return similar to what it was before. But I don't know when that might be.
But you're optimistic.
Yes.
That's your perspective on life, I think.
Yes.
Or at least you're going to make sure it is.
I hope so.
So you are, I would put you in the optimistic category and the hopeful for Duke continuing the medical operation and enterprise continuing to be top notch in the United States and the world?
It has to be. There's no other way.
Why does it have to be?
Because that's who we are. And as I mentioned earlier, that's how we grow. We grow by being the best. And I can't imagine it being any other way.
Well, I'm appreciative of the fact that you are truly a Blue Devil now and have been left behind your dip into the University of North Carolina system. And even at the basketball games, you're a Blue Devil?
I am. Yeah.
Well, congratulations for the transformation.
Thank you.
Is there something that you would like to share about your career? Just you, not your usual unselfish conversation about Duke and the institution, but something that you're most proud of in your own career?
Well, I got into the business or administrative side really fairly quickly, moving from the chief medical officer to the CEO of the University Hospital very quickly. I enjoyed that, but I continued to take care of patients. I continued to see patients up till about 3 years ago.
Is that right?
4 years ago. So it was never wanting to get away from patient care. It was the attraction of potentially being in a role where you could multiply the impact you might have. I mean, medicine is a very personal profession, and there's nothing more powerful than the one-on-one relationship of a caregiver and a patient. At the same time, I had the good fortune of being in a position where decisions could be made that may have impacts on hundreds or thousands of patients there. And so it's always been about patients. It's not been about business. And I hope I've done a good job at helping others help patients in the Duke Health System.
Thank you. That's a wonderful way to put it. And I think Duke has been lucky that you have had these important roles in the healthcare system. Is there something that stands out particularly? I think your whole career, in many ways, you're proud of. But is there a moment or something in particular that stands out for you?
I don't think there's one moment that I could refer to. I think it's just, as I said, it's being able to help lead us in a path that I think is something I'm very proud of around that. And I'm proud of what others have done for each other and for our patients and their families over the last 30 years, and hope I've done something to positively impact that.
What is there that makes you most proud, that gives you a true feeling of happiness and accomplishment all at once?
When I hear a patient talking about their care here and their caregivers here, and how wonderful their experience has been.
Well, it sounds like they have you to thank for a lot of their positive experience. It's not always that the leader of a health system emerges from a career as a physician and a researcher. So how does your origin story help explain your success as an administrator?
Well, I've told people before, I think I've led hospitals the same way I practice medicine. And that is, you've got to have great teams. You've got to trust each other. You've got to pay attention to details. And you've got to act when it's necessary. And there's not a whole lot of difference there. As I mentioned, I went back and got an MBA a number of years ago, a couple decades ago, because I wanted to know the nuts and bolts of business too. At the same time, it's about the patients and what's best for the patients. And I think you can take what I think is the most important things about caring for patients and apply them to the business of running hospitals as well.
That's not always the approach that hospital administrators take.
Well, that's the way we do it at Duke. Okay?
Is there something about Duke Health that stands out and makes you most proud?
Just the great care, and on the academic side, the great science, the clinicians come to work every day wanting to care for patients. The researchers come to work every day trying to invent new therapies, and so it's really all about the patients.
The synergy that you've seen throughout the decades of your career, is that like a secret sauce? Is that?
I don't know if it's unique at Duke or not. Out of my fellowship, Duke is the only place I've worked. But it really is that way at Duke. There is tremendous mutual respect for all the missions and the people who work on those missions here. And there's a lot of interdependence, as I said. The academic product is key to the brand of Duke Health System. And so it's important for everybody to be successful here and to depend on each other.
Depend on each other is what patients do with their doctors a little bit, and vice versa a little. The patient depends on the doctor, but I think that relationship, it sounds like you are carrying that up to the hospital administration level, which is not an easy task.
It's not, but I've told the administrative folks that worked with me over the years, from the very young ones to the very seasoned ones, that their role was just as important as the surgeon in the operating room, and it was their job to get better every day too, to learn something new every day that would improve the service that they were in charge of or delivering there, and we've had some amazing people.
Well, thank you for your service to Duke and for giving us a chance to have this conversation. It's been a pleasure. Thank you.
It's been a lot of fun. Thank you.
Thank you, Bill.
All right.
And we met the deadline.
All right, good.